So good evening, everyone. I'm Dr. Louise Jones. I'm chair of Healthwatch Camden, and it's my pleasure to chair this public meeting this evening. On your screens, you are able to see just a few people, and I think that you won't be able to see each other because of the design of the format of the session. We are recording the meeting. So on your screen, you will see the team of Healthwatch Camden. So you have Namrata, Shelley and Anna, and Matthew, who is our director. And then we're joined also by three of the other trustees, Robert, Philippa and John at the moment, with apologies from two or three others who unfortunately can't make it this evening. And we also have with us our guest speaker, Sir Michael Marmot, who will be talking to us for about 15 minutes or so shortly. And then we will there will be an opportunity for you to ask questions, which we would ask you to put in the Q&A box, type into the Q&A box as we go along. And we hope that there'll be an opportunity to put some of those questions to Sir Michael later on. We have also got some questions that have been submitted in advance, and I will be asking those to kick things off. Then we'll have some discussion amongst the board, and Professor Marmot is with us for about 45 minutes to an hour, and he's welcome to stay for the second half of the meeting if he wishes, but he may wish to go off and get his supper. But the second half of the meeting is the board meeting that we hold in public several times a year. So you're welcome to stay on, and if you feel that you wish to, please do, or if you feel you've had enough, we won't be offended if you go off and get your supper too. But we would encourage you to submit any questions that you've got as we go along. And in the most interesting part of the second part of our meeting is we will be talking about some recent work that we've done on the COVID-19 vaccine, views of people who are seldom heard. So mostly people from the BAME community on their views on the COVID vaccine, and we'll be presenting that report. So Sir Michael is going to speak on the topic of building back fairer, and some of you will know him or know of him. He is an international expert on the causes and consequences of health inequalities. He has led research groups on health inequalities for over 40 years. He is a professor of epidemiology at University College London, director of the UCL Institute of Health Equity, and past president of the World Medical Association. So if you're ready, Michael, I'll pass over to you and we'll hear what you've got to say.
Thank you. Let me start at the end. I was talking to a group, I talked to a lot of groups recently, and one of the people in the group said, well, we've done so brilliantly at handling the pandemic. And I said to him, you know, Danny Kahneman, a psychologist, won the Nobel Prize for Economics. And one of his many contributions was to show the evidence that people's memory is very much influenced by the most recent thing that happened. This commentator was clearly looking at the success of the National Health Service in rolling out the vaccine and saying, we've done a great job in handling the pandemic. He's forgotten 2020 completely. And I make a point of that, not to score political points, but unless we understand what went wrong, it's going to be much harder to put things right. And to relax and say, well, everything's just fine. Look, we rolled out the vaccine, so we've handled the pandemic well. And ignore what happened before that is a dangerous misdiagnosis. And in fact, I go back not just to 2020, but to 2010. Well, really, to 2008. In 2008, we published a report. I had chaired the Commission on Social Determinants of Health of the World Health Organization, and we published our report, Closing the Gap in a Generation, a global report looking at health inequities globally. And in the wake of that global report, the Prime Minister of the UK, then Gordon Brown, invited me to conduct a review of health inequalities in England, addressing the question, how can we apply the conclusions and recommendations of your global report to one country, England? So I did, and we produced the Marmot Review, Fair Society, Healthy Lives, in 2010. And in February 2020, I looked back at the previous 10 years and asked what had happened, how we did. And it was not a good picture. Life expectancy, which had been improving about 1 year every 4 years for 100 years, stopped improving at the same rate. In 2010-11, the rate of improvement slowed dramatically and just about ground to a halt for men and for women. Health inequalities increased. Health follows what I call the social gradient. If you classify people by where they live and classify where they live by level of deprivation, the more deprived the area, the shorter the life expectancy. It's not just poor people have worse health than everybody else. It's a social gradient. And that social gradient got steeper over the 10 years. The inequalities got bigger. And if we look at regions, now, Camden, you can congratulate yourself. If we look at regions, for people in the least deprived 10%, it didn't much matter which region of the country you lived in. Life expectancy improved a bit over the 10 years. The more deprived you are, the area in which you live, the greater the disadvantage of living in the northeast or the northwest. So the social gradient is steeper in the northeast and the northwest than it is in London and the southeast. And life expectancy for the poorest people went down in every region outside London. So before the pandemic crashed upon us, we had a slowdown in improvement in life expectancy, increase in inequalities, and health for the poorest people outside London was getting worse. Now, one of the clear conclusions we drew from the Global Commission on Social Determinants of Health is that health tells us a great deal about how well society is functioning. If health stopped improving, it means society stopped improving. If health inequalities got bigger, it means inequalities in society got bigger. And the obvious question to ask is, what happened in 2010-11? Well, we had a new government elected in the wake of the global financial crisis, a Conservative-led coalition government. And I hasten to add, I approach these issues not from a party political point of view, but looking at the evidence. And as you'll remember, unless you're blinded by recent memories, the Kahneman effect, but if you're not blinded by recent memories, you'll remember that the government had one priority, which was to cut public expenditure, to roll back the state. And they did it. In 2009-10, public expenditure was 42% of gross domestic product, and by 2019, that 42% had shrunk to 35%. And the state was rolled back in a regressive way. If you look at spending by local authorities, the more deprived the area, the greater the reduction in spending. So in the least deprived 20% of areas, spending went down by 16%, and in the most deprived 20% of areas, it went down by 32%. So even the best off had a reduction of 16%. And one of the questions that was submitted in advance relates to the phrase that I coined in my 2010 review, proportionate universalism. I said we want universalist policies with effort proportionate to need. What we got was effort inversely proportionate to need. The greater the deprivation, the greater the need. The greater the need, the greater the reduction in spending. Now, this is not a neat experiment, but could this regressive reduction in public spending have led to a slowdown in health improvement and an increase in health inequalities? Yeah, it could. It's entirely plausible. And in my 2010 review, I had 6 domains of recommendations. Give every child the best start in life. Education and lifelong learning. Number 3, employment and working conditions. Number 4, everybody should have at least the minimum income necessary for a healthy life. Number 5, healthy and sustainable places in which to live and work. And number 6, taking a social determinants approach to prevention. Most of those got worse in the decade from 2010 to 2020. And then came COVID. It seemed utterly predictable that COVID would expose the underlying inequalities in society and amplify them. And so it proved. Both COVID and the effect of lockdown increased social and economic inequalities. And that's why I produced a second report called Build Back Fairer, only 10 months after the first report of 2020. And it was based around those 6 domains of recommendations from my 2010 report. Give every child the best start in life, education and lifelong learning, employment and working conditions, having enough money to lead a healthy life. Number 5, healthy and sustainable places in which to live and work, including housing. And number 6, taking a social determinants approach to prevention. I called it Build Back Fairer. People were talking about Build Back Better, but I wanted a more equitable distribution of the social determinants of health and of health. Because what we had before the pandemic was far from acceptable. Build Back Fairer. We've now produced a second report with that title. I chaired a commission on social determinants of health in the Eastern Mediterranean region of the World Health Organization. That's North Africa and the Middle East. We're about to produce a third report with the Build Back Fairer title in Hong Kong. So it's got some resonance. Let me finish by saying the second most common question I get asked, have been asked over the years, is what's the one thing you would recommend? And it drives me bananas, because if I thought there was only one thing to recommend, I wouldn't have had 6 domains of recommendations. The most common is, don't you get tired of banging your head against a wall? No one's listening to you. And my evidence-based response to that is, that's not true. There's a lot of people listening. Coventry declared itself a Marmot city. Greater Manchester said, well, if Coventry can be a Marmot city, Greater Manchester can be a Marmot city region. We're working with Chester and Merseyside. Gateshead. We just recently had conversations with the North of Tyne Combined I'm excited. I don't think I'm banging my head against a wall at all. Where we're not getting action at national government level, we're getting action at city, regional, local level. So there's a great deal of interest. And the last thing I want to say before we open to questions, it's also not true that it's being ignored at a national level. The Prime Minister was asked in Parliament what was he going to do about the Marmot report, and the Prime Minister, who, as we know, tells the truth all the time, said, I admire Michael Marmot. I thought, well, that must be true because he always tells the truth. We've worked together for a long time. I thought, you'd think I'd remember that, actually, if that were, but he always tells the truth. And please be assured that we will implement his recommendations as we build back. So that was reassuring. I briefed the Lib Dem peers, and Labour asked me to brief the shadow cabinet, which obviously helped enormously in the recent elections. So that's very reassuring. But so it's not actually true that it's being ignored at the national level, although it is the case that over the last 10 or 11 years, not much has happened at the national level. But there's a great deal of interest internationally and a great deal of interest at local level. So if Camden wants to take this on, terrific, absolutely terrific. Now I'm open to questions.
Thank you very much, Michael. That's very nicely put, all of it, I think. And I guess it's interesting to hear the scope of your thinking and the scope of your influence. But in life generally, I think most things happen in small ways, which enables things to happen in bigger ways. And I guess the first thing I would like to say is, how can organizations like Healthwatch make more of a difference than we do already? Or are there areas in which you think that the local health watches, Healthwatch, or Healthwatch England, we are statutory, we do have a voice on the local authority. And I wonder if you have any comments on what you think we could do better or how we could contribute.
Yeah, I do. Most people who are involved in health are involved in the healthcare system, and it's understandable. I'm having a conversation tomorrow morning with the Western Pacific Regional Office of the World Health Organization. They've got a strategy for the next 5 years that they want my advice on. And one of the comments I'm going to make to them, and it's the same comment that I would make to Healthwatch, is it's too closely allied with the healthcare system. Now, I'm not saying that you are, but the conversation I'm going to have with the people in Manila tomorrow, to say that their draft strategy is too closely allied to their healthcare system. What they should do, and I would say the same with Healthwatch, is recognize the social determinants of health and who can we partner with? Who are the key partners here? For early childhood, we documented in my 10 years on report that child poverty had gone up. Child poverty had gone up. The proportion of children living in households at less than 60% median income had risen. 1,000 Sure Start Children's Centres nationally had closed. It's vital for the health of our children that we try, doing something about child poverty. Now, there's only so much can happen at local level. That needs national level. But secondly, how important services are, such as children's centres, to break the link between poverty and poor early child development, and so on. We can go through my 6 recommendations through the life course: early childhood education, employment and working conditions. In Coventry, for example, they managed to reduce the proportion of 18 to 24-year-olds who are not in education, employment or training need. They increased the proportion of people earning a living wage by working with local employers. So there's a lot that can happen, and a group like Healthwatch can be great advocates for working across the key sectors that represent the social determinants of health.
That's a very useful advice for us. And our remit is to represent the views from the grassroots. And we do try and work in partnership, but it's good to be encouraged to do so more. I've got a nice comment here from Henry Langford, one of our participants, saying, in Camden, we're producing a new joint health and wellbeing strategy, drawing directly from your work and looking closely at the Coventry model. We're listening and we'd very much like to seek your advice too. So I think there's an opening there, Michael, for you.
Well, good. I mean, we're only limited now by just how many hands that's not the royal plural, my small number of colleagues and I, how many hands we have to give advice, but we're very open. Because, let me divert for a moment. After I went to a meeting in Stockholm about 5 years after we published the Global Commission report, and a member of the Swedish Parliament said, the half-life of Commission reports is about 6 weeks, but your Global Commission report is still being discussed in the Swedish Parliament 5 years later. Next time you're in Stockholm, I'd like you to come to the Parliament and meet the Social Committee. So I was going to Stockholm a few months later to attend something called SALAR, the Swedish Association of Local Authorities and Regions. There were 280 local authorities and regions represented in the room, and the level of enthusiasm was palpable. It was terrific. People said, yep, this is what we want to do in every local area of Sweden. So the next day, I went to the Social Committee at the Parliament and said, I'm delighted you're still talking about my report. I'd be even more pleased if you did something about it. It's funny, they didn't ask me back. I don't know why. But anyway, and then I said, look, I went to Salah yesterday, and every local authority in the country is palpitating with excitement about social determinants and health equity. And if you don't do something at national level soon, you'll find that the population's passed you by. And then you'll do what politicians often do. You'll wait till 95% of the population's marching in one direction, and you'll run round the front of the march and pretend you're leading it. Well, for that reason or for some other reason, it took a while, but then they set up a national commission on social determinants of health in Sweden, which then passed into law in Sweden. But the action started at local level and only latterly was taken up at the national level. So what happens at local level is of vital importance. I want national action, but local action is of vital importance.
John, I think one of our trustees, John Hoare, would like to raise a question.
I've been listening to this, and
Thank you.
Well, no, basically, I think it's fantastic stuff. But my question is there a can we get some simple messages that can be adopted by the public and by individuals who are interested in this, and to some degree get some sort of groundswell going that then the politicians can come around and march around to the front of it? And can we play a part in actually distilling some of the key sort of messages, and maybe even just coming out with, I don't know, 5 key messages, or if there's 6 areas, then a message for each, that basically can create a very simple message that can be disseminated, almost like the ill-fated Labour Party election promises. I remember their card that they were waving around. But having something that basically people can identify with, that it's sort of really quick and simple, so that you can almost get a groundswell going that can then, the politicians can then get to the front of if they wish to.
Well, I think we've got the opportunity here for a wonderful partnership. I'll give you the science and you give me the simple messages, because that's not my special expertise. I mean, when I briefed the Labour Shadow Cabinet, one front bench shadow minister said, look, we're very nice people and we're not getting our message across. How should we be communicating with the public? And my comment was, a few things come with age and experience, and one of them, in my case, is recognizing what I'm not good at. And what I'm not good at is telling politicians how to communicate with the public. I can tell you what I do, which is I tell the truth, I base my comments on evidence, and I try and engage people in discussions of social justice, of what the right thing is to do. So I have no idea what the simple message is. I can tell you what we said, but it seems to me Build Back Fairer has more resonance than Get Brexit. Get Brexit done. What did that mean? Levelling up. What does that mean? Does levelling up exclude Camden, or does it include Camden? Does it include Newham, or does it exclude Newham? Build Back Fairer, I think, is a start. And then we've got those 6 domains. Give every child the best start in life. Number 1. It seems to me that's not bad. Give every child the best start in life. When you think, what I've been highly critical of, the slogan of the government elected in 2010 was to reduce public spending. Wow, what a model. What a worthy aim in society. Not how can we create a better society, how can we improve health and well-being. I mean, what I said in my Build Back Fairer report, in addition to my 6 domains of recommendations, I said, put equity of health and well-being at the heart of all government policy. And I think a lot of things that we did over the last decade, we would not have done had we done that. So I'm very happy to work with you. I'll give you the evidence and you come up with the catchy phrases that communicate with the public.
Thank you very much. Following on from this is a nice question from Diane Pearson, has come through on the Q&A system. She says, thanks for this very useful conversation. I'm a councillor in Camden and sit on the Health Scrutiny Committee. I'm aware of your approach of social determinants of health that is much wider than only focused on the health system. But since we and many in the community are highly concerned about the upcoming Health and Care Bill, I would like to know your opinion of it, and if you have some advice on how to approach a wider assessment of it in line with the social determinants of health. Quite a meaty question, I think.
Yes, it is. I mean, firstly, it's not much trumpeted as being that, but the upcoming change to integrated care systems is saying the Lansley reforms in 2012 were what we all knew, utterly misguided. And so this is a complete about-face, which is good. I mean, it's not being trumpeted as a complete about-face, but that's good. Whereas the Lansley reforms were how much of the NHS can we privatise, and the more market competition and the more lack of coordination, the better. this is saying the more integration, the better. I suspect privatization is still a goal, although it's not being trumpeted. So that's already a start. Of the various local authorities that have approached us, some are thinking about their integrated care systems and asking how they can be vehicles for addressing social determinants of health. A starting point is to think of healthcare institutions as anchor institutions. I think the idea came from the US, but it's being taken up. The Health Foundation has taken it up. The idea that you look not only, firstly, the healthcare system, the NHS, employs 1.4 million people. So the quality of working conditions for NHS employees, and if you add in the social care system, I don't know how many more that is, but difficult as working conditions are in the healthcare system, they're far worse in the social care. And it's hard to call it a system. It's so fragmented and messed up. So health and social care as anchor institutions, looking at the quality of working life, but looking at the impact on the community, purchasing decisions, the social value of purchasing, the environmental impact on the community are all absolutely vital. And then using the opportunity of developing new integrated care systems to work in partnership, what I was saying a few moments ago, to work with others to address social determinants of health. So I think that it's a welcome change, a welcome reversal of the Lansley reforms. And the more people who work together to try and take advantage of this opportunity, better. So it doesn't get fragmented and be another vehicle for privatization of the NHS, which would not be in the national interest.
Thank you. Robert, did you have a question? You unmuted yourself just now. Did you have a question?
No, that was an error, but I'll go for it.
Okay.
Michael, I'll try to rephrase the obvious question that you don't like. What is the one point? But I'll put it in this way. If your audience tonight, we know, consists of at least one councillor, there may well be others. Do you have any particular message, given that the political representation in Camden with Keir Starmer and Tulip Siddiq is of the Labour Party? Is there any particular message you'd have for the Camden local authority at the moment?
Yeah, very much so. What I said a few moments ago, put equity of health and well-being at the heart of all policies. And if you ask, yes, but what does that mean in practice? Aha, now I'm in conversation. I can tell you what it means in practice. What it means in practice is implementing my 6 domains of recommendations. So to think through the life course about quality of life for the youngest in society, for people at school, leaving school, university, training, etc., working life, and older people. And we've got a whole series of evidence-based recommendations, but you've got to want to do it. And wanting to do it means putting equity of health and well-being at the heart of all policy. If it's local policy, regional policy, national policy, or indeed global policy. The criticism of the cuts to the Official Development Assistance Budget, ODA, aid. If you put equity of health and well-being globally at the heart of all policy, we would still be spending 0.7% of our gross domestic product on overseas development assistance. So it's what's true in Camden is true nationally, and it's true globally. And, still on the global, Gordon Brown wrote a piece a couple of weeks ago at how the G7, which we're leading at the moment, should come up with $30 billion a year for global vaccine rollout. And that should be part of our responsibility. $30 billion, you think, is that a lot? Well, President Biden's first COVID recovery bill was $1.9 trillion, and his next two bills are going to be about $2 trillion each. 30 billion doesn't sound terribly much, actually. We used to, I don't know about you, but I used to worry about the price of carrots. And, the price of carrots seems to pale to consideration with the amounts of money we seem. How much did we waste on test, trace, and isolate? 38 billion pounds we wasted on an ineffective system. You can buy a lot of carrots for that. So $30 billion a year among the G7 countries doesn't sound like a lot. Put equity of health and well-being at the heart of all policy, whether it's in Camden, nationally, or globally.
That's very useful. And I think we've got a question from Noelle Skivington, who's a representative of one of the other local Healthwatch. And I think you've covered mostly her question, which is how Healthwatch could help to make change happen. And I think it is through what you're saying, through integrated working and collaboration and working in partnership. And I think that that's a very strong statement that we certainly at our level can take forward. I have a question that was submitted earlier, which I don't think you've seen, Michael, which so we've had the inequalities highlighted by the pandemic. What do you think we can really learn from the pandemic, because and how we can use the pandemic as a platform to go forward? Because it's front and foremost in people's minds and affecting both their health and their social well-being and mental health and other health inequities because of the system provision, the waiting lists and the backlog and so on. Have you any reflections on how we can use it as a springboard to?
Yeah, very much so. At the beginning of the pandemic, I showed a slide around for a while, which was the effect of Hurricane Maria in Puerto Rico. And if you look at the deaths caused by Hurricane Maria in Puerto Rico, you remember those images of that president, what's his name, who was president before Biden, the one between Obama and Biden, but I'm trying to suppress his name. That ghastly image of him throwing paper towels around a room as his way of dealing with the problems caused by Hurricane Maria. If you look at mortality by socioeconomic level, the excess mortality was quite low in people of high socioeconomic level in Puerto Rico. It was fairly high in people of medium socioeconomic level, and it was very high, the excess mortality, in people of low socioeconomic level. So you get a big external shock like a hurricane, and it amplifies the underlying inequalities in society. And that's what the pandemic has done all over the world, not just in the UK, all over the world. It amplifies the inequalities in society. And then lockdown comes along, and that amplifies them further. As we documented in my Build Back Fairer report, you see the increase in mental health problems, more in low-income people, particularly in younger people, particularly in younger women, increases in domestic violence. The lower the income, the more likely people were to be working in shuttered sectors. So they either had to go out and exposed themselves to the virus in frontline occupations, or lost their jobs and were furloughed because they were in shuttered sectors. We saw the increase in food insecurity that had to be addressed by the agency of a young footballer who shamed the government into acting. If a young footballer can shame the government into acting, maybe Camden can shame the government into acting, or the Healthwatchers together can shame the government into acting. But so we saw all of these inequalities being exacerbated, firstly by the pandemic, and secondly by the societal response to the pandemic. So that's where we are. And that's why I talk about Build Back Fairer. And the first thing I would say, the first lesson to learn, is that austerity was a huge mistake. A huge mistake. It damaged health and increased health inequalities. Don't make the same mistake again. Now, I'm inclined to believe some economists and not others, I suppose. I'm biased in that way. But my understanding is that we don't need to worry about debt. When interest rates are so low or even negative, now is not the time to worry about debt. The illiteracy, the idiocy of saying the nation is maxed out on its credit card, I mean, it's just monumentally stupid to be governed by people whose view of economics is that the nation is maxed out on its credit card. When did a family engage in quantitative easing? Oh, we're in debt. Our household's in debt. We'll get the Bank of England to print more money, and we'll adjust the interest rates. I mean, it's nonsense. So now is not the time to be thinking about austerity. Now is the time to be thinking about redressing the problems that were in existence before the pandemic and were made worse by the pandemic. The second is what we recognize, what we should have learned through the pandemic, is how important the government is, how important the public sector, and not just national government, but local government, city government. And part of the reason that we did so badly had been the disinvestment in public services in the decade up to 2020. We were ill prepared for the pandemic, and we were ideologically disinclined to believe that government could do anything good. And now and so the nonsense of putting the test, trace and isolate out to some private sector corporation that was ill-equipped and ill-trained to do it. Why didn't they give that to local government and local public health? Look how brilliantly the NHS did in managing the vaccine rollout. So redressing that ideological commitment that private is good, public is bad, is a second important lesson to building back fairer. And then thirdly is wanting to put equity of health and well-being at the heart of all policies. And the practical implications of that are laid out in my report and are the kind of things that we're recommending to Greater Manchester, that Coventry's been doing, and that Gateshead has laid out in their plans, and that we hope to be working with these other areas that I mentioned.
John, you wanted to come in, I think.
Yeah, it comes back to my messaging thing, because the more I'm listening to this, I'm thinking the average man or woman on the street or person on the street basically has a sort of instinctive wish to do good. However, they are very strongly driven by the second thing, which is natural preservation, and basically, I'm all right, Jack, and it's not my problem to some degree. Obviously, the pandemic has illustrated that it's everybody's problem. But in terms of health inequalities, is there any way of couching this in terms of, I remember Margaret Thatcher won the sort of her second term. I mean, basically she was down and out, and it wasn't for the Falklands War, and quite frankly, also the the fact that she came up with this WISO policy, which I know has positives and negatives, but basically allowing people to buy council houses and buy their own property and get on the property ladder, which basically meant that people felt better off and felt better about themselves as families. It was a really sort of good way of creating social change that basically was bought into by the vast majority of the population, or certainly those that saw a vested interest. And so what I'm trying to think is, again, trying to get this messaging across so that actually it becomes in everybody's best interest, not to be giving people a hand to help them up, to level out the health inequalities, which is very laudable. But how do we make it so that basically it's in everybody's best interest to do this, in terms of actually it's a sort of a really, there's a positive reinforcer that actually says actually you're doing yourself a favor as well.
Well, if you look at the social gradient in health, in healthy life expectancy, between the best off 5% and the worst off 5% is about a 17-year difference in healthy life expectancy. But it's a gradient. It means people in the middle have, on average, 8.5 years shorter healthy life expectancy than people at the top. People in the middle are affected by the social gradient. It's not just the poor. It's
well, that's kind of the messaging that probably that will probably get a lot more traction than talking about a 17-year, than actually say, look, if you're in the top 1%, you get 17 extra years. But if you're in the top 5%, you actually lose 5 years. Now, I mean, if you sold that in terms of smoking cessation, you get a lot of people living up cigarettes.
So if you're in the middle, on average, it's 8.5 years fewer healthy lives, years of life. And so it does affect all of us. We're all affected by this. And I mean, I know the figures, but just to give you an anecdote, at one point we employed a Scottish woman who was married to a Finnish man, and she'd been living in Finland, and she thought, oh, it'd be nice to come back to the UK. And then she realized what it meant. Subsidized childcare? Nope, forget it. Cost of housing in London? Wow. So she tried it for a short time. So I'm going back to Finland. That I wanted to come back to the UK, but subsidized childcare. When I wrote my book, The Health Gap, I saw the figures of 5 years out of date. I don't know what the current figures are, but for a family with 2 children, the cost of childcare was about £11,000 a year. I don't know what the current figures are, which means that if both parents wanted to go out to work, it would cost them about £11,000. So could you imagine, you're living in Newham or Camden, and you're not on a high income, and if you want to go out, the other parent wants to go out to work, you've got to pay £11,000 in childcare. Well, how much do you have to earn to make it worth your while to go out to work?
Not worth working.
In Sweden, it cost £1,000 a year because it was state subsidized. So that benefits the people in the middle, not just the poor. It benefits everybody. You've got high quality childcare because being a Nordic country, they've got high standards and quality control and goodness knows what. They do studies of how stressful it is for a carer to have 5 children to look after rather than 4 or whatever. So being Sweden, they do all that stuff. So you've got high quality, quality controlled, subsidized childcare, that benefits the middle classes, not just the poor. That benefits everybody. And that's why I talk about proportionate universalism. We want universal policies that benefit everybody with effort proportionate to need. So the greater the need, the greater the effort, but policies that benefit everybody.
But how does that, I mean, does that tie into crime figures? Does that tie into things that would either make people go, gosh, we need to do more of that? Or
It does. I've had the police after me. Please don't misunderstand. But I've spoken to 2 police conferences in the last 2 or 3 months. If you look at our Build Back Fair report, or is the 10 Years On report, and look at violent crime, it had, I think it was in the 10 Years On report, there was a dip in violent crime, and then it went up again, and it follows the social gradient. So the least deprived 10% have the lowest rates of violent crime. The most deprived 10% have the highest, but it's a gradient. So if you're in the middle, you've got more violent crime in your area than if you're at the top, and so on. It's a finely graded relation, which means there's real benefit in terms of civil disorder, violent crime, health, everything you can think of follows the social gradient. Now, why has that happened, that rise? It may be because of the cuts to youth services may have played a role. It may be a late effect of cuts to children's centres. Yeah, that 10 or 15 years later, 10 years later, you've got children who had less good early child development because the lack of access to children's centres are then more likely to be antisocial. And it's interesting, the enlightened police understand this, the importance of early child development to reducing crime. They understand this.
These are really good comments, thank you. And they also address some of the last couple of questions that we've got from the public. We've got somebody who hasn't given their name, who's really asking the question that you've really just been answering, which her question is, in creating equity, how would you ensure that you don't reduce good health and social care outcomes that may have already been achieved? So how do you create levelling up? Is there a minimum standard? And I think really you've kind of covered that. And how does that get agreed? So this kind of idea of a gradient, and that we're all on that gradient, doesn't matter who we are, I think is a very useful way of thinking about it. And there's a second question from Ruth, who says, lower socioeconomic sector have always fared worse in every way. We know this. Social work is far worse now than ever before. Have you any ideas on how we can make it fairer? And I think in a way you've covered some of those thoughts in your comments.
Fund it.
Yes, fund it indeed. Find a way to fund it sensibly. And let's hope that something comes forward now with this new parliament. Whether it will or not remains to be seen. I don't know, we are coming to the end of our time now. We have another 5 minutes technically, but so I don't know if anybody else on the panel, or if there are any more burning questions that anyone wants to ask, or if you have any last minute things you'd like to say, Michael.
Well, John was asking about the man or woman on the street. A while ago, I was catching a train. This is before lockdown, catching a train, and it stopped at Clapham Junction, and somebody got on. I thought, it was not quite the man on the Clapham omnibus, but close to it. And it was fairly crowded. He sat down next to me, and he looked rather shabby. He was wearing frayed jeans, and he just looked a bit shabby. I thought probably an unemployed builder's labourer or something. And he put on some reading glasses. I thought, I wonder what the man on the Clapham omnibus reads. And he took out a book, and I looked over his shoulder, and it was Herodotus, the Histories, Volume 7. So my message is, don't underestimate the man or woman on the Clapham omnibus. I think their understanding, their capability to understand these things is vitally important. I mean, when I said the two questions I get asked most often about aren't you tired of banging your head and what's the one thing you do? Sometimes people say, what if you were Prime Minister for the day? What would you do? And my response is, I'd mess it up. What Prime Ministers always do. I'd mess it up because we have to work together. I don't want to replace one dictator by another dictator. I want us to work together. That working together is actually part of the solution.
And everybody benefits and everybody learns on all sides by doing that.
Yeah, the
Yes.
journey is important. So no, if I were Prime Minister for the day, I'd make a mess of it. And I want us all to learn together.
Thank you very much. We do have one person with their hand raised. I'm sorry we can't take questions directly. But if there are any further questions from anybody who's listening, if they would like to email us with the questions, we can pass them on and maybe try and answer them outside the meeting. I think we'll probably draw this part of the meeting to a close now, Sir Michael, if that's okay. And thank you very much indeed for your insights and for your wisdom and your honesty in the way you've discussed your work and our issues. And it's been a pleasure having you with us. You're very welcome to stay if you wish.
Don't take it amiss, but I will leave because
yes,
I've some other things to do.
Of course.
My pleasure.
Thank you very much indeed.